science writer Amy Alkon, whose work challenges the assumptions we make about medicine, particularly when it comes to women's health. So in today's conversation, we'll unpack the research, the myths, and the real-world consequences, and we'll talk about what needs to change in clinical practice, institutional education, and public discourse to better serve women at this critical stage of life. So you're right that healthcare for menopause and perimenopause, this is like the 3 to 10 years leading up to menopause, is the medical field's most patient-betraying area. Why do so many women get dismissed, misdiagnosed, or flat out denied treatment?
Well, there's a big secret of gynecology departments, a scandal, which is that almost none or none of the gynecologists in any department in North America have any training in menopause or perimenopause treatment and education whatsoever. So you're going to doctors who are, it's unethical for them actually to treat you because a doctor can't treat out of their specialty. If they don't have any training, they need to refer you to someone who does have training. The problem being that if there's no other doctor there who has any training and they don't understand how to diagnose you, what the symptoms are, and women come in just feeling miserable in every way. Now, not every woman is symptomatic, but many women have all these different symptoms. They take drugs they don't need for diseases they don't have because of misdiagnosis and just lack of understanding by doctors.
You identify these 3 key myths we believe about our medical care.
So the 3 big myths about our medical care are that medical care is evidence-based. That's the first, and that's the biggest. That doctors decide your care based on scientific evidence, that they can read studies and do read studies and critically evaluate them and decide your care on them. The second one is that doctors are not trained. We believe that doctors are trained in diagnostic reasoning. They're not. The Dr. House thing where they do this differential diagnosis where they figure out what is the underlying condition that is causing your symptoms, because you don't want to treat a symptom. But if doctors can't diagnose you, that's what can happen. And the third is that doctors cannot properly assess your risk level. They cannot do the calculations. And so they, if you ask a doctor, what's my risk of getting this disease? Or what's the benefit, the percentage of how likely am I to benefit from taking this drug or having this treatment? They can't actually tell you. And patients need to understand what the risk is, why they would go for a treatment, what the diagnosis is, how evidence-based that is. And all of this is just missing from medical institutions and medical education.
How women are treated during perimenopause and menopause.
We are dismissed by ignorant doctors. We are told, you have hot flashes, tough out the symptoms. Women are given estrogen in perimenopause. So women get very sick. And part of the problem is that they're often not making progesterone, the partner of estrogen in the menstrual cycle, that they're not ovulating. The period seems normal. But when you don't ovulate, progesterone is made out of the little sac, the litter from the sac that the egg ruptures from and is released from. And so no sac rupture, no litter, no progesterone. And you need that for sleep, to not be mentally very unwell. My mental health was basically like rims on the highway in one of those freeway chases because I didn't have the progesterone I needed to keep me in a normal mental health state. I learned from the research of this endocrinologist that progesterone was what had gone missing in me. And there are ways to evaluate, to look for this, to collect data from yourself using first morning temperature to see if you're ovulating and making progesterone. And so I went to the doctor and said, I need this drug, the generic, because they give generics at Kaiser, the generic for Prometrium, the brand drug, oral micronized progesterone, FDA approved. Very important to get the FDA approved drugs because they're regulated and you're getting what it says probably on the label, whereas the compounded drugs, you're not. And this changed everything for me. I started sleeping. My hot flashes, went to very low and night sweats. But the doctors wanted to give me estrogen also in perimenopause. And I knew, let's not overdose me on the hormone that's skyrocketing and making me sick. And this is the kind of care women are getting. And unless you're me and this crazy scientific mole rat who loves doing this deep dive and can do it, you're imperiled by your doctors, by everyone. And especially, as you said, this is the most patient-betraying area since the doctors have zero training, most of them, and zero education, zero ability to diagnose you properly or to properly treat you.
And I can't imagine how traumatic it must be when you're like so deep into it and nobody's willing to help you and everything gets worse. And it's like, you feel like you're going crazy and you're putting on weight and like the things that you did previously just isn't working anymore and nobody can give you answers. And then I Google my symptoms and I'm dying of cancer, and it's just like the anxiety is like, it's just intense. Like it was so crazy. It has just put me on this in the space where I'm like, I don't really trust anyone, not even like the traditionally trained doctors, not the new age trained doctors. You know, I'm going to have to be in this space where I have to do all the research myself.
She tells me, oh, but estrogen raises SHBG. And I said, no, oral estrogen does, but I'm taking transdermal estrogen, which is the healthiest, the safest kind to take because it doesn't have the effects of the big blast of estradiol you have to take with oral, because that goes to the liver first and transdermal goes to the skin. So you don't have what's called first pass hepatic effect, which is about your liver chomping up all the estrogen and sailing it out of your body. And so the fact that she's saying this, no other patient's going to know that.
Women's Health Initiative study from 2002.
They announced it's so fraudulent and terrible. In 2002, they said in healthy menopausal women that taking estrogen, taking hormone replacement therapy, increase your risk of breast cancer and Alzheimer's and a bunch of other conditions we don't want. And so the reason it's fraudulent is that they did not test healthy menopausal women. A bunch of this was tests on women who are like 75, 79. So grandma's not going to the doctor to ask for an estrogen prescription. If you stop estrogen at 60, like the head of gynecology suggested to me, told me to do, because she's basing this on the 2002 discredited research, discredited in 2004 and beyond, you reverse the gains you've had for your bones, because estrogen is very helpful to bones, estrogen and progesterone together, and then you're unprotected at 79 when you need to have this estrogen in your body protecting your bones. They're not saying, I'm sorry, I can't treat you. Primary care doctors, they have no business treating menopause. They give women antidepressants because those do help with hot flashes. However, they're not treating all the symptoms and problems of your hormones being, progesterone being, missing. And it's called practicing defensive medicine, where a doctor, instead of prioritizing your health, prioritizes their fear of being sued for malpractice.
So from a patient's perspective, how do we take the care and advocating for ourselves into our own hands?
So these questions to ask your doctor: can you lay out your reasoning behind your diagnosis and the treatment you're recommending? Could there be other conditions that are causing my symptoms? What are my risks from this treatment? Are there safer, less invasive alternatives? What can I expect during this treatment and what sort of recovery? And do I need this now, or could I wait or go without the treatment? Now, your doctor may not be able to answer these questions. And if not, get a second opinion or a third opinion. Bring the science to your doctor. Knowing the science for yourself is vital.
What is the standard of care? So what is it that the doctors have to default to kind of meet the insurance company's stipulations for treatment?
There really isn't a standard of care. They don't know what it is. What they need to do is to treat me as an individual, give me double dose so I get the adequate dose. But they're saying, oh, that's super physiologic. No. And the Menopause Society says we need to treat patients as individuals. Well, they're quoting me and they're saying the Menopause Society says we can't do this. Well, no, I read their bulletins, along with the evidence, and they're very slow to confirm the evidence, to say, oh, there's all this evidence. Okay, let's make this our position statement. I'm really naive. I'm from the Midwest and a kind of a Pollyanna, where I just think, oh, everything will be wonderful. And I say, well, okay, now that I showed you with all this evidence, good RCTs and everything, will you give this to other women? Will you give this to the rest of your female patients? I was like, no, naive girl.
We are so scared of breast cancer, but we are being distracted from the real threat.
1 in 5 women right now die from cardiovascular diseases.
I want to ask, so which tests do you recommend for women in perimenopause and menopause?
You can't test estrogen and progesterone. Those tests are a waste of money. Changes, it pulses, it goes up, goes down. It can change every 20 minutes. You diagnose perimenopause through the symptoms, but not just the symptoms. We have this clever way, this quantitative basal temperature taking. This is very important to do, where you take your daily temperature. Geraldine Pryor's, it's in my book, how to do it. It's very simple. Write it down, see what your temperature is. to see if you have too few days of progesterone, if you're not making progesterone, which means you're not ovulating. This looks at, have you ovulated?